First of all, I would like to thank the organization and the colleagues for the invitation to this very exciting meeting. For me, it's the first time that I come in Lisbon, so especially I would like to thank my friend Rufino, Dr. Rock, for the welcome of yesterday. Thank you very much. The first thing that I learned coming here, that there are here in Lisbon two football teams that are Benfica and Sporting Lisbon. So I respect both because I understand, I follow football, so I understand which type of reality is this. So now we are trying to speak about the age-related macular degeneration, which could be the best approach to try to help our patient to solve this type of problems. We start with the number. We know that in our country, age-related macular degeneration is the most important cause of the legal blindness for our patients. But I would like to start with another type of approach before to speak with which could be the best treatment regimen, because the first thing that we have to observe in our patient is which type of lesion we are going to treat, because it's very important to decide which is the best approach. I show you this slide. This is an old slide because this was the first classification that we observed that was very, very simple. We share in three categories the type of neovascular lesion that we go to observe that was predominantly classic, minimally classic, and occult. And you have to consider that the first study about the use of photodynamic therapy or the first study about anti-VEGF considered this type of old classification. But we know that with the increasing of technology and in our knowledge, we observe other type of lesion like polypoidal lesion or like retinal angiomatous proliferation, that is a lesion that starts from the retina and go deep inside the choroid. I like to show this image of the first OCT that I have in my clinic because I explain clearly what we mean for a neovascular lesion that starts from the retina and go too deep in the choriocapillaris. But until now, with era of angio-CT, so some colleagues of me speaks very clearly about the new perspective of the angio-CT, we observe a lesion like this one that we consider obviously like a central serous chororetinopathy, but if you observe this case with angio-CT, what we discover? We discover that there is, in this case, a network of vessels. So what I mean that the first thing that we have to do is to identify well what type of lesion we are going to treat, and after to obtain the best results, which is the best treatment to do. This is the story of our approach to this type of pathology. So we start from nothing that was laser photocoagulation that was limited only to determinate case like extrafoveal lesion to arrive until now with the exciting era of multiple choice where the discussion which is the best choice that I can do. And now we go to speak about the treatment regimen. Just to summarize what we know well, I imagine, we have two principal scheme of treatment, that is fixed treatment of proactive, that we define like proactive treatment, and the pro-renata treatment that we define like reactive treatment, which is the difference between the two schemes of approach of the disease, that we speak, when we speak about proactive treatment, we speak about a fixed regimen. When we speak about pro-renata or reactive treatment, we speak about a treatment that after the loading phase, we follow step by step if decided to inject again or schedule in the future the next injection. So which are the clinical trials that show us which is the best way to treat our patient? We start with the study of a prepared set. I go fast because I don't want to bore you with a lot of numbers because we know the story, but it's important to understand which is the way that protocol trials suggest us like the best way of treatment regimen. View study say to us that after obviously the loading phase that I think that you are all agree that we have to do, the best results for what concerns a fiber set for maintain the gaining of visual acuity that I have after the loading phase is to administrate our drug after each 2 months. So we speak about a fixed regimen after the loading phase of 2 months of injection. what say to us ranimizumab? The ranimizumab study was older, obviously, the aflibercept, because ranimizumab we have able to use before that aflibercept, but which is the substance that we observe, make a summary of all the study, that you obtain a better results when you do a mandatory treatment regimen. So a fixed treatment regimen that you see here, like the orange line. So what concern the gaining and the maintaining of visual acuity, what suggests us the protocol trial that we obtain the better result maintaining a fixed regimen or 2 months for what concern aflibercept, of each month for what concern ranimizumab. Okay, and this is probably a dream world, you know, that because we know that in our clinical practice it's very hard to follow this type of regimen for our patient, for what concerns the organization of our activity, for what concerns the economical burden that this means. So in real life, what's happened? And now we try to answer to this type of question. So essentially, which is the best option that I can follow to obtain the best results with our patient, but that could be a compromise what the real world that we each day affront in our clinic and the dream world that sometimes proposal the protocol trial. And this is the real world. Our study, what say to us? This is a study that developed in Europa country, and what observed that after the initial gaining for what concerns the visual acuity, our patient lose progressively during the follow-up what we obtain after the loading phase. So what does it mean? This means that we don't treat the patient in the right way, or we don't follow the patient in the right way. So for this reason, we start to go slowly in the real world. So we start from the protocol trial that give us, which is the best option that we can do, but in a real world, we cannot follow this for any reason that we know well. So which could be a compromise to obtain a good results for our patient? This is the question that I try to ask. And for this reason, some authors try to make a comparison between the PRN treatment that, as I told you, as needed treatment, and the treat and extend, that could be a good compromise between a fixed regimen and as needed treatment. And what we see in this publication, that if we apply to our patient a treat and extend treatment, we obtain better results comparing with as needed treatment. This is other example that I show you. You see that after the loading phase, when you apply PRN treatment, you lose the gaining of visual acuity, but if you start with treat and extend, you obtain a new gaining like the before of the visual acuity. And the same data you obtain with aflibercept. So after the first year, we switch to treat and extend treatment, and we maintain the same gaining of visual acuity. So what does it mean? What means that treat and extend could be a good compromise for the treatment of our patient. But why do we decide to do this? So it's not a number that we like, 1 injection, 2 injection, 3 injection, loading phase, treat and extend. Our knowledge is based on the observation of the life, the time of vasopressor of the VEGF inside the vitreous. These are numbers important. This is the average, because in each patient change the ME life of the drug inside the vitreous. So the average for what concerns ranimizumab is almost 37 days of life of the VEGF inside the vitreous. For what concerns aflibercept, we know that the time is longer. So we speak about almost 71 days. This is the reason, because we enlarge the time for what concerns aflibercept when we schedule our program of injection, comparing with ranimizumab. So we know that this is important to try to have a better organization for our clinic, for our patient, to give up the best result that we do, and to simplify the life to the relative of our patient, because we know that in clinical practice, they have to come with some relatives when they do the injection, when they do the visits. Sometimes they have low vision. So there is a whole familiar organization that have to support our patient. For this reason, for us, for our organization, and to give them a better quality of life, is better to try to organize better our activity. So in summary, what we have to do? We have to avoid, obviously, to make an over-treatment. That could be, for example, if you follow the fixed treatment regimen. But we have to care to avoid an under-treatment, how our studies show us. And so the treat and extend, as I show you in the literature, and as I prove in my experience, could be a good compromise to obtain a better result for our patient, a better result for the organization of our center. And does it mean that we have to calculate the maximal fluid-free interval between one injection and the next, and schedule the next injection before, obviously, that we have a relapse of fluid inside the vitreous of each patient. And this is a chart where we see the single points of proactive treat and extend treatment comparing with fixed regimen and as needed treatment. So, in summary, what we can do, what we can say that treat and extend represent a good compromise for treat our patient. This is a good summary between what we could do in the dream world that represent the fixed regimen and what we can do in the real world, that what we do each day in our clinic. So which are my conclusions, which I can suggest you like rules to make a measure, a custom therapy for our patient. First of all, we have identified which type of neovascular lesion we are going to treat, because as I show you at the beginning of my presentation, there are different type of neovascular rejection that we are going to treat with different prognosis, a different type of approach. I show you an image that concerns the polypoidal lesion. We know that polypoidal lesion have a good response to photodynamic therapy, plus the use of intravital injection, or RAP lesion, or other type of lesion. So I criticize my colleague that, for example, at the beginning of the pathology, doesn't do all the exam to the patient, but make only OCT. OCT is good for the follow-up of the patient, but at the beginning is very good to make all type of exam to identify exactly what we are going to treat. The second line, obviously, the choice of anti-VEGF therapy, more efficacy to treat the type of lesion. In my experience, where I have, for example, RAP lesion with a large exudation, with the serious retinal pink epithelial detachment, very huge, I obtain better results, for example, using aflibercept, comparing with ranibizumab. So, different type, different choice of anti-VEGF. Value, if basing of the type of lesion, the possibility of alternative therapy, like I told you before, photodynamic therapy for what concerns the polypoidal lesion. And in the end, the treatment regimen, I told you that in my experience, follow the literature, the treat and extend is a good compromise of what we can do. This is my equipment university that I thank because they solved me yesterday a very dramatic problem, because I arrived here with my train drive, and the presentation doesn't work. So they send me immediately from the university all the presentation, so I have to thank them always. Thank you very much.